Welcome to part 2. In part 1, remember we reviewed just the basics and some of the rules about fetal monitoring. And in part 2, we're actually going to dive in and learn how to read the strip. Remember that to determine the baseline, it takes a 10-minute time frame to establish a baseline. And we're going to look at where it hangs out most of the time and then round that off to the closest 5 beats per minute. We know that a normal heart rate range for a baby is 110 to 160. If this heart rate is hanging out at the 130 line, and it bumps occasionally up to the 135 and occasionally down to maybe 128, 127, then if we were kind of to draw a line through that, the place it hangs out most of the time would be the 130 line. When we're looking at baseline, we have to look at baseline when there are not any contractions happening and when we don't have a period of a big increase in fetal heart rate, like an episode of our increase or some type of a deceleration. And you're going to learn to define those. But to start with, the easiest way, and I think I told you in part 1, the easiest way to learn how to look at this fetal monitor strip is go one page at a time and let it build on top of each other so that by the end, this is going to make sense. So for right now, heart rate baseline is where does it hang out most of the time, rounded off to the closest 5 beats per minute. And where is it hanging out when it's in its baseline, in between contractions? A normal fetal heart rate baseline, we said 110 to 160. So bradycardia is anything less than 110, tachycardia anything greater than 160. And then we do occasionally have something that's called indeterminate. It's kind of wild looking and kind of all over the place, so you can't really tell where it's hanging out most of the time. Fortunately, we don't see that too often, and when we do see it, it's a sign of a very unhealthy baby that needs immediate help. So we're looking at this picture, and we're going to call baseline right here because this is in between contractions. These are the contractions on the bottom part. So what is happening during this, we can't call baseline. So the only place that we really have a place that we don't have contractions is this place right through here. So this would be what we would call baseline. Now, because this is a training picture, it doesn't really have all the increments that we would have on a real fetal monitor paper. On real fetal monitor paper, you would have 90, 100, 110, 120, 130, probably 140, and then 150. And so if you were to draw a kind of a straight line through here where it's hanging out most of the time, and I can say this only because I've done this for so long, I could guesstimate that that's probably going to be about 130. I would never expect you to be able to pull that out of this particular strip since you don't have your 130 and your 140 line. But this is basically to show you that you're going to look right here where we're in between contractions. Because what's happening right here during the contraction, we cannot call that baseline. So here's a picture of bradycardia. Here's the 60, 70, 80. If we were to draw a line through here it's going to hang out at the 80 line. There's some that's a little bit below the 80. Here's one that probably goes up to about 88. But if we were to draw a straight line, we would say this is probably right about 80. Now, we've got contractions here, so we can't call these baselines, but we do know that we've had something happen, and this is not good, even if it's with this contraction. It appears that we've got some time in between the contraction over here. I've got about a minute showing right here, and it is at 80 right here. But it takes a nosedive, and so we'll look at this, and this is hanging out in the 50s. Occasionally, maybe 55 right there, 55 right there. But if we were to draw a straight line, the place it hangs out the most is at the 50 beats per minute. This kiddo's in trouble and he needs some help. And you're going to learn to know exactly what to do when you see this strip. If you notice, toward the end of this, we've got our fetal heart rate baseline going back up to about the 60s, 55, but the 60s right there. And that's still not good because it needs to be 110 or higher. So determining whether the bradycardia is an emergency or not, first off, remember we said we always need to make sure we're not recording mom's heart rate. So you see a pattern like that, the first thing you need to do is take mom's pulse and find out if what you're hearing is exactly what you're feeling with her pulse. And if it is, it means we're recording mom and not baby. Or most of the time it means that we're recording mom and not baby. So we would want to readjust that TOCO to see if we could get a better picture. We're going to determine if this is an acute or a chronic change. Has this baby been hanging out? Say that it's a 100. And yes, that's just a little bit below 110, but 110 is our cutoff. So anything less than that, if it's hanging out at less than that, that's a concern and has to be evaluated. It's not close enough. It's less than the 110, so we're going to evaluate it. So say this was hanging out at the 100s. We would want to look back in her prenatal record and determine whether this is normal for this baby and whether this baby has been worked up for this. If it is, then that's a chronic change. Hopefully they've been evaluated by perinatal medicine and we're not going to be too concerned about that. If not, we see that she's done this in the prenatal clinic, we're going to call them and find out what they've done about that. And if they haven't done anything, we need to do something about it. Or is this an acute change? Is this something that's happened since the last time she was seen? And if she's seen in her prenatal clinic and we see in the prenatal records that the baby's heart rate during her prenatal appointments are the 130s and now we're seeing 100, then this is an acute change that we need to evaluate. And then we're going to look at baseline variability and determine whether we've got an emergency or not. So here's tachycardia. This is sitting here in the 180s. If we were to draw a straight line through this, it really is on the 180 line more often than it is someplace else. Yes, we have some above that. Yes, we have some below that. But if we were to draw a straight line through about where the median of this is, it's going to be in the 180 range. What causes tachycardia? Well, some things going on with mom are going to cause tachycardia in our infant. If mom has a fever, it's going to cause our baby's heart rate to speed up because they're in a hot environment. If mom is starting to get an infection, drug abuse, things like cocaine can cause this. Methamphetamines can cause this. If mom's dehydrated, we don't have a good blood flow through that umbilical cord and through that placenta. Therefore, we don't have good oxygen going to our baby. And the only thing our baby can do about that is speed up their heart rate because they need more oxygen. If mom is on medications called beta sympomimetics, then that can increase mom's heart rate and the baby's heart rate. And one of the drugs that we use frequently in OB that would cause this is a drug called terbutaline. You'll find that on your antepartum prep sheet in your meds. We use that to treat preterm labor. And then if mom has got hyperthyroidism, it can cause an increased heart rate in our babies. Then our fetal causes, things that are going on with the baby that is causing this tachycardia, is their response to mom's fever. If they are starting to get infected themselves, that can cause an increase in heart rate. Our babies do have arrhythmias. If baby is anemic, and again, they don't have enough trucks to carry the oxygen around, so their body is saying, I don't have enough oxygen. The only thing their body can do in response to that decreased oxygen is increase their heart rate to try to get the oxygen to the tissues that need it. Hypoxia and then heart failure in our infant can also cause this. Here's a picture of that indeterminate baseline that I told you about. I can't tell you where this is hanging out most of the time. Is this the baseline and this is some kind of a decrease? Is this the baseline and this is an increase? I don't know. This increase is different than this increase. So baseline here, baseline here. I don't know. Is this a baseline? I don't know. because remember, we cannot call a baseline. Baseline is in between contractions. So that looks like maybe over here, here's a contraction. This really has not returned to baseline. So she's still having some kind of a contraction right there. Whoops, sorry about that. She's still having some kind of a contraction here. This doesn't look like it really comes back to baseline. So I think she's still having something going on there. Another contraction, probably pushing or throwing up, or something's going on here. Contractions don't look this spiky. I would say based on like these spikes right here that she may be trying to push, but I'm not sure because I wasn't there. But I can't tell you what the baseline here is. I can tell you this baby is in trouble though, because I can't determine a baseline. This baby's in trouble. So I'm going to be doing things like IV, O2, turn her, and hope if this doesn't get better immediately, I'm calling the provider to come see this woman. She will not stay on my unit looking like this more than about 5 minutes before I call somebody. Here's another strip. If we look and we draw a line where this fetal heart rate hangs out most of the time in between contractions, here's the 120 line, there's the 130 line. Would you buy that it's hanging out about halfway between 120 and 130 most of the time? So 125. Stimulated, meaning that we did something to stimulate that kiddo. Typically what we do is we have like a little vibrator that we put on mom's tummy, and we just kind of go bzz, and it startles the baby so they wake up. And when they wake up and move and get startled, they have this increase in heart rate right here. And we're going to define that in a few minutes. But that's a good thing right there. That is not part of the baseline. This is not part of the baseline. This is not part of the baseline. Right here is our baseline. These little FM marks right here, that's fetal movement. Either mom said she felt baby move, or the nurse standing at the bedside saw or felt baby move, and they put it on the paper. Now we're going to talk about fetal heart rate baseline variability. That sounds like a mouthful, but what it really means is the fluctuation in the heart rate from beat to beat. If you think about what you've seen when you've been in critical care and you've seen somebody on the monitor, like on the pulse ox, and you watch their heart rate, it will show 72, 79, 73, 75, 68, 72. It's not a steady, it's not an exact number all the way across. It fluctuates. And so if you were to have a visual representation of just those beats, not the QRS complex, just those beats, what you would see is what we call variability in our newborn. And so variability is a baseline characteristic. It is what is happening in the basic part of the baseline. It's based on a visual assessment. We're not pulling out calipers to measure something. We're just going to look and see what that range looks like. So here's our ranges right here. This is what we see. This is what we're going to document. And we have to document variability of every time we talk about the fetal heart rate. We're going to talk about what its baseline rate is, 125, with minimal variability. And that's going to tell us a lot, and you'll understand that here in just a little bit. So if we were to look at our fetal monitor strip, and it looks like somebody drew the fetal heart rate on that paper using a ruler, because that is so flat, we call that absent. There's no change. It's 125, 125, 125. Undetectable is at least there's something, but it's 5 beat variation or less, and we call that minimal. If we look at it and we see that that variation from beat to beat, that range of heart rate is 6 to 25 beats per minute, we call that moderate. And I'm going to show you pictures of this, so this will make sense here in a minute, I promise. Moderate, if you see the stars right here, it's because moderate is what we want. Moderate tells us that we have a kiddo that has an intact central nervous system, who is a mature fetus, meaning at least 28 weeks. And it means that our baby has good oxygen. He's telling us he's doing okay in there. If, on the other hand, we see that we have this variation, this fluctuation from beat to beat that's greater than 25 beats per minute, we call that marked. Marked always, always, always means our baby is hypoxic. This is not a good thing. We need to do something about this. Minimal and absent. Absent, that's probably always going to be a hypoxic kiddo. And that one's kind of hard to tell because, oh my goodness, if this is a 27-weeker, they may not be able to fluctuate their heart rate very much. So we would have to kind of keep it in mind what that gestational age is. But if this is a mature fetus, greater than 28 weeks or so, absent and minimal variability, along with marked, tells us we have a hypoxic kiddo. Marked is always going to tell us that we have a hypoxic kiddo. Moderate always tells us that we've got an intact central nervous system and we have a well-oxygenated kiddo. Here's a picture of that. If you look at this, this looks almost perfectly flat. Sorry, it's hard to do my little cursor on the screen and not forward it, so I apologize. There is some fluctuation right here. We're talking probably 2 or 3 beats per minute right here. There's a little one right there. There's a little one. But overall, the visual representation of this top one is flat. There's not a whole lot of wiggles here. So this is what we call absent. If this is a mature kiddo, this is a hypoxic kiddo. This one has a few more fuzzies on the baseline, and those fuzzies are a lot bigger than those, okay? But again, it's relatively flat, and those are really equaling 5 beats per minute or less. And so we call that minimal variability. Now, if we look at this, the change kind of from beat to beat, if we go from here to here, this is probably about almost 20 beats per minute. Okay, and so over here we've got probably about 10. So we've got fuzzies and we have some bouncing on our baseline. And I'm going to tell you just from experience, this is not part of that. We're going to call that something else when we look at other terms here in a few minutes. What we're talking about is what's happening right through here. Okay, now on this one, this is marked variability. These beat to beat changes are greater than 25, okay? This might be an acceleration like those, I'm not sure. But if we look right through here, even if we're not sure what to call that, we can tell that this right through here is greater than 25. And so this is just kind of all over the place. This is going to tell us that we probably have we do have a hypoxic kiddo. This kid needs oxygen. We want it to look more like this. So here's another example. This absolutely positively flat. You might see this little wave right here, but that's not a cycle between beat to beat, because this is over probably several seconds, 10, 20 seconds right through here. But this beat to beat there isn't any change. This beat to beat is very minute. So we call that minimal. This one is average. We don't use average anymore. That used to be a classification, but we're not using that. So we go from 0, less than 5, and then 6 to 25. If you look at this beat to beat, this change from beat to beat through here is 6 to 25 beats per minute. We call that moderate. That's the one we want. And then this is marked. We're going from beat to beat is kind of all over the place. All right. If you were to look at a strip on a test, it's not going to be real nebulous. It will be pretty obvious if they ask you to define it. So here's an example when we're talking about minimal. They're showing the change of 5 beats or less. Looks pretty flat, but we do have some fuzzies. Here's that picture again. Looks pretty flat, but we do have some fuzzies. We do have some beat-to-beat change. And we have more beat-to-beat change than on that first one, because there are fuzzies here instead of a pretty flat line. Here's our moderate variability. The change, the normal rate and the change from beat to beat is 6 to 25. Notice that they've excluded these big things because that's not part of the baseline. That's an episode that has happened on the baseline, as opposed to something that is ongoing on the baseline. I hope that makes sense. And then here's our marked variability, greater than 25 beats per minute. It's just kind of all over the place. You can't call a baseline here because it doesn't settle any place long enough for a baseline. This is a very concerning strip. All right, let's talk about a couple of our terms that you have to know. The first one is an acceleration. And I want you to think about an acceleration like you do with a car. And if you accelerate the car, it means increase. So a fetal heart rate baseline acceleration is there's an increase. It's an abrupt increase of 15 beats above the baseline. So if you were at 120, it has to get to 135. And it has to be off the baseline for at least 15 seconds. And we call that a 15 by 15. That means it's an acceleration. If you say that you have accelerations, you are saying that you saw this visually apparent abrupt increase of 15 beats per minute times 15. And all you have to do is say, we've got a heart rate baseline of 120 with good accelerations. Boom, you're done. And you've said that you've got everybody in their mind's eye will be able to know exactly what you just described. So onset to peak is usually equal to or less than about 30 seconds. Anything when we're talking about on our baseline, anything that happens and it lasts longer than 2 minutes, we're going to call it a prolonged, whatever it is we're talking about. If something on our baseline happens for greater than 10 minutes, then we call that a new baseline. 10 minutes to establish a baseline. So if this is a visually apparent abrupt increase, and so we have this increase of 15 beats per minute above the baseline, and it returns within about 30 seconds or so, we're going to call that acceleration. If that increase lasts 2 minutes, we're going to call that a prolonged acceleration. If that heart rate continues at, like we said, 120, so it goes up to 135, if it stays up at 135 for greater than 10 minutes, that baby has now established a new baseline, and we document that the baseline has been reset to 135. So here's a picture of a strip. So here's the 120 line right here, 130, there's the 140, there's the 150. So where is it hanging out most of the time? In between the contractions. It's hanging out most of the time right through here. So I would probably call that 135. And then we have these big increases, this big acceleration. And this accelerated up to the 160. And this lasted about a minute. We've got good variability. We've got good fuzzies on our baseline. They're not greater than about 25 beats per minute. So that's moderate variability, well oxygenated. Here's another accel going up to almost 160. Another accel going up to 160. Another accel going up. We've got contractions down here. These are all contraction. This kind of stuff on the baseline right through here, she's pushing. That's what these big spikes are. That's what this big spike, these big spikes over here are. Because contractions don't spike like that. They're usually nice and rounded, more like this one, okay? This squaring off and those big spikes on there typically means she's pushing and she's tightening her belly so that it's causing pressure up against that little button on the tocodenometer. Fetal heart rate deceleration, just like if you decelerate your car, you slow it down. And the title is based on when this decrease happens in relationship to the uterine contraction. With an early and a late, those you can only have those if you're having contractions. You cannot have an early, you cannot have a late in the absence of contraction. Since they happen with a contraction every time, those are called periodic patterns. An early decel is a visually apparent gradual, see that gradual underlined right there? You can see it. It's a gradual decrease in the fetal heart rate, and it returns to baseline by the end of the contraction. When you look at these, it starts to decrease about the time the contraction starts. It reaches its lowest, the heart rate reaches its lowest point, typically at the peak of the contraction. As the contraction starts to ease off, the fetal heart rate goes back up to its baseline. It is back at its baseline by the time the contraction's over. If they mirror each other, that's an early deceleration. As opposed to a late is also a gradual decrease in the heart rate. Typically, it's going to start to decelerate after the contraction has started. It tends to reach its lowest point after the peak of the contraction. And the most important part of this definition for this work, for a late, is that the contraction is over prior to the fetal heart rate returning to baseline. So if you're looking at this, it's a gradual decrease. It returns to baseline after the contraction ends. That's always a late. And do you see, based on these definitions, why you can't have an early or a late without a contraction? You can have a decel, but you cannot have an early deceleration or a late deceleration if you don't have contractions, because it's based on the timing of the contraction. And then our variable, an abrupt decrease in the fetal heart rate. You might see those only with contractions, or you might see them even if you don't have contractions. So a variable can be a periodic or it can be a non-periodic. Just have to define and state that with about 50% of her contractions, she has a variable decel. And this is an abrupt decrease as opposed to the gradual for the other two. And this variable can look like a V, a W, or a U. So what causes early decels? It's caused by head compressions. So as mom has a contraction, baby's pushed down, pushed up against the pelvic floor. The vagus nerve in the baby's head gets stimulated, and that causes a reflex slowing of the baby's heart rate. That's why as that contraction eases off, baby comes up, back up in the pelvis a little bit, off the pelvic floor. That vagal nerve stimulation stops. Heart rate's back to normal by the time the contraction's over. I'm going to give you a hint on how to remember these in a minute. Just walk with me through these and get these understandings, and then I'm going to show you an easy way to remember these. A late deceleration, remember, returns to baseline after the contraction is over. A late deceleration tells us we've got a placental problem, placental insufficiency. There is something preventing good oxygenation to that baby, and we have to investigate why, and we have to fix it. The reason this doesn't start until after about the peak of the contraction, when mom has a contraction and they're at least moderately strong, remember your chin, if they're at least moderately strong, then the blood flow through the placenta ceases during that part of the contraction. And our babies that are healthy can tolerate that. Our babies who have minimum oxygen reserve, on the other hand, you tell them to hold their breath for 30 seconds, they're going to decompensate. So the contraction starts, it reaches its peak, blood flow through the placenta stops, baby's not getting any new oxygen, he can't compensate, the only thing he can do is drop his heart rate because he didn't have enough oxygen. So his heart rate's going to drop. The contraction is over. Blood flow is reestablished through the placenta. It's going to take a minute to be absorbed across, travel through the cord, travel to the baby, travel to those chemoreceptors to get that heart rate back up to normal. A variable deceleration is caused by something with the cord. There is cord compression somewhere, either from a nuchal cord, which means that it's a cord wrapped around the baby's neck. It can be a cord wrapped around part of the baby's body. There can be a knot in the cord, a short cord, poly or oligohydramnios. Remember we said that's decreased amount of fluid around the baby. It means that cord is very vulnerable and it can get compressed during contractions. It can get compressed as the baby moves around and bumps into that cord. We can see this because we have a prolapse cord, that cord coming down in front of baby's head before the baby is delivered, and it gets compressed by the baby's head. Remember, they can look like a U, a V, or a W. Now I'm going to show you a picture of what these look like kind of side by side. So the early looks pretty uniform. If you look at them from contraction to contraction to contraction, they look pretty similar. This is showing you that they're happening at the same time. They start about the time the contraction starts. They end when the contraction ends. It usually doesn't drop below 100. It really doesn't mean anything. It means mom's probably progressing in her labor. And so we're going to continue to monitor, and that's all we really need to do. Now, if it's been 5-6 hours since we've checked her, we may want to check just to make sure that baby's not getting ready to come in and say hello. But if we checked her 20 minutes ago and there hadn't been an appreciable change in her contraction pattern, it just means that baby's moving down and we don't really need to do anything. Here's our late. Again, these look pretty uniform. Here's our contraction. It starts. Our baby's doing okay. About the time we get to the peak of this contraction, the blood flow through the placenta stops. We're not transferring O2 to our baby anymore. Our baby, who is compromised, decompensates and drops their heart rate. Here's the end of that contraction. It does not return to baseline until well after that contraction. We've got to get blood flow back through that placenta that's not working well. And typically, if that was working well earlier, we had a healthy placenta, this insult would not hurt this kiddo, just like this one. These could be the same strength of contraction. But when we have good blood flow, our baby holds his breath during that contraction, no problem. This baby didn't have any reserve to begin with. And so this contraction insults him every time because he can't go that 30-40 seconds without his oxygen. Usually occurs in a normal fetal heart rate range. Again, usually doesn't drop below 100. Means that there's decreased O2 available to our baby. This is a hypoxic pattern for our baby. So what do we need to do about it? We need to turn her IV O2, turn off her Pitocin. We need to improve blood flow through that placenta. And then here's a variable. This is a V, this is a U. All right. These, just for this picture, are happening with the contraction. But remember, variables are the only one of these deceleration patterns that can occur in the absence of contractions. Because all it means is that the cord is insulted. It has nothing to do with the placenta or the contraction. So it can be a U or a V. If it happens with every single contraction like this one, this is the one that makes you think that this is probably a body cord or a nuchal cord. And so during that contraction, baby's being pushed down, that contraction or that cord's being compressed or pulled as that baby's pushed down. And so it drops the fetal heart rate. It often does drop below 100. These are abrupt, these are gradual. It can result in hypoxia if those continue for every single contraction, or they, we're having them every minute or whatever, or they're lasting 30, 40, 70 seconds. Even healthy babies are going to get insulted with that, and it's going to start causing some hypoxic patterns. We need to change mom's position. We need to check for a prolapse cord if change in mom's position hasn't worked. O2 by mask and maybe her IV. Increase her IV to give her a little bit more fluid. So here's our picture. Here's the start of the contraction, the end of the contraction. Here's our decrease. It's back to baseline by the time the contraction's over. There's an acceleration, an increase in our fetal heart rate. Contraction, peak of the contraction, about when that heart rate drops. Important part of this definition, returns to baseline by the time the contraction's over. Our acceleration tells us we've got a good oxygenated baby. We've got good variability. We've got a lot of good fuzzies on this baseline. Tells us this is a healthy baby. She's progressing in labor. That's all this means. This is a reassuring strip. Here's our late. Here's the onset of the contraction. Here's the peak of the contraction. About the peak of the contraction is when this baby starts to decelerate, not back to baseline until well after this contraction. The good news right now is we still have some variability. So we've got a placenta problem, but we do have a well-oxygenated kiddo for now. But we better fix this, or we're going to start seeing a baby that's decompensating even worse. So I have a few more minutes. This one doesn't make me panic as much as I would panic if this was absolutely flat, because both the absent variability and our late decel tells us we've got a hypoxic kiddo. So variable decelerations, onset to nadir, meaning the lowest point of this is usually less than 30 seconds. Like an acceleration, we only talk about those decreases if they're more than 15 beats per minute and they last for more than 15 seconds. A variable deceleration is the most common type of episode you're going to see on the baseline. And so we don't document every single one of them. We only document the ones that are significant, the ones that are lasting 15 seconds, and we're still not going to document every single one of them. We're going to say that they are having a pattern of variables of approximately 3 a minute, or 3 every 10 minutes, or 3 every 30 minutes, rather than every single one. Again, if it's less than 2 minutes, it's a variable. If it's longer than 2 minutes, what are we going to call it? Longer than 2 minutes means it's a prolonged variable. If it lasts longer than our 10 minutes, it's going to be a new baseline. So here's some pictures of some variables. There's probably some accels. There's a big whopping variable. So we would document this one. This one dropped down into the 60s, sorry. And so here's some variable. This dropped down to, looks like maybe 110. No, that's 50, 60, 70. I can't read those numbers. Okay. And so we're going to document these. These are happening with the contractions. I would clean this contraction pattern up a little bit, see if I could get a better looking strip on there so that I could tell exactly when those contractions start and stopped. We know that the doc came in the room. He did a vaginal exam just to make sure we don't have a prolapse, because I'm sure we were probably seeing this before. And so we're going to watch this one. Again, look, we've got good variability through here. This is moderate variability. We've got good fuzzies on our baseline, starting to decrease a little bit over here, but over here it looks good. We start to flatten out too much, and these start getting much bigger or much deeper. We're probably going to expedite delivery, as in she's 5 centimeters. She's only halfway through. She may end up with a cesarean delivery because our baby is not tolerating this. But if this was all we saw and then we went back to a regular strip without a lot of these, because we turned her, gave her O2 and oxygen, we kept our variability, we're going to let her continue to labor. Mild and severe variables. Hopefully you'll agree with me. This is a mild. It lasts, there's 10 seconds, there's half of that block, so that's probably 20 seconds long. It went from maybe the 150s, 145, down to 120. Okay, no problem. We've got good variability. Do you see, this is variability. This is baseline. This is something that's happening on the baseline. This is a variable. Variability, it's a baseline characteristic. Variability, variable. Variable is an episode as opposed to an ongoing thing. I'm hoping this is making sense. The hard part about online education is you can't tell how your audience is understanding what you're saying. This is a severe variable. This is about 1.5 minutes long. It drops down into 50, 55. And not good variability right there. We come back out of here and don't have good variability. Minimal right through here. This might be 5 beats per minute or 6. This, since I really can't call it, this I feel comfortable saying it's at least 6. This, not so much. Maybe that little bit right there means I'm going to have to watch this. The good news is it didn't happen again after this contraction. Here's a prolonged deceleration. If we were going to call, say, the 145, 150 as our baseline, we start to decrease right here. So there's 1 minute, 2 minutes, so we know it's prolonged, 3 minutes, 4 minutes, 4.5 minutes, going into 5 minutes, and we're still not back to our baseline of 145, 150. It hasn't resolved as of right here even. But I'm going to turn her, I'm going to give her oxygen, I'm going to give her IV, I'm going to try to slow these contractions down to let that baby recover. All right, here's an easy way to help you remember this. Think about the word veal chop. This will help you determine what is causing the pattern you see. So these are the patterns, this is what causes it. We said a variable is caused by cord compression. Early decel is caused by head compression. An acceleration tells us our oxygen is okay. We're fine with accels, we like those. Our late deceleration is placental insufficiency. We need to do something about this. Just a reminder about our prolonged decels. We said that through this, you're going to be able to interpret the fetal monitor by looking at the baseline rate. Hopefully you can look at a strip and tell where it's hanging out most of the time. Talk about the variability. How much fuzzy is on that baseline? Variability is a baseline characteristic. Then we have the presence of accelerations. Do you see an increase in that heart rate? At least 15 beats above its baseline for at least 15 seconds. Do you see periodic or episodic decelerations? Can you tell me without looking back in your notes right now, what 2 patterns are a periodic and what pattern can be either a periodic or an episodic? Then look at the change over time. Hopefully if it was 120 over here and now you're looking and it's 135, you can tell that's a change over time. And then the frequency and intensity of contractions. And that's the end of this part. Take a brain break and then come back and let's look at this again.